seminar series. Today we have an eminent superstar academic among us, Professor Tarun Khanna. And I see many of first year early program PhD students. And I know when I started my PhD journey, you started off with Khanna et al., and so on and so forth. Institutional voice. And pretty much the entire course work on strategy, the institutional side, is has been a pillar of that intellectual body of work. And it is an honor and pleasure to host you here. And thank you for deciding to drop by. And on a very short notice, is flying back at 6. So we have everything end to end done. Again, on the decision, thank you so much for agreeing to deliver this talk. The formal introduction. Professor Tarun Khanna is a George Paulo Lemann Professor at the Harvard Business School and Director of the Lakshmi, Mittal and Family Association Institute at the Harvard University, where he has been a distinguished faculty member since 1993. His academic expertise lies in the section of strategy, innovation, and entrepreneurship. Particularly, he explores how entrepreneurs and companies navigate institutional voids. The major body of work which I just talked about. And if you've been infected with too many of Khanna et al. Papers, here's the culprit. You can take your vengeance as it needs to be. With questions, of course. Beyond academia, Professor Khanna actively contributes to practical initiatives aimed at fostering innovation, ecosystem, and emerging markets. In fact, today's seminar on the health ecosystem, Reimagining India's health system, is going to be part of this very important work that he's leading. He has done multiple other initiatives in this space. Today we'll be talking about in generally enhancing social well-being and economic development. Today we're talking about India's health system. He's also a prolific author with notable publications, including Making the Prophecy, Leadership to Last, How Great Leaders Leave Legacies Behind, Trust, Winning in Emerging Markets, and Strategy and Execution, and billions of entrepreneurs. Professor Khanna holds a Bachelor of Science in Engineering from Princeton University and a PhD in Business Economics from Harvard University. His work has earned him recognition as Young Global Leader by the World Economic Forum, along with appointments to various prestigious boards and advisory groups worldwide, including several government, non-government, corporate advisory boards that is pursuing today in India. So, thank you once again. The stage is all yours, and 45 minutes to an hour, and you can decide how you like to interact with the audience. Okay, and later.
See how we start our class. And the faculty has to attract attention. So that's a good thing. Thank you. It's nice to be here. I'm telling you to like myself over because I always want to see the campus, and I had a lot of friends who go through there. And so I called my colleague, and it was nice enough to it's real pleasure. So I brought a bunch of slides about this project that I'm currently part of. I can do this talk without a single slide. I show you all the slides. We can have a discussion. Let me tell you what's in the slide, what the project is about. My preference would be to have a conversation throughout. But obviously it makes sense to see some information. So perhaps in the spirit of making it up as we go along, I'll show you some slides. We have a discussion about it and go to this part. So let me back up for a second. I'm very interested in both my academic work and practical non-academic work in the institutional foundations of economies. And in particular, how program using best for grew up in India, and so this is grown for me. And they was spread word, export. We still had last year I got struggling in some ways. And that's really the first thing I like, is to think through some of the structures we put in place. And then, in the last, so I've been professional academic base, 30 plus years. And the last, the second half of that has also been spent taking some of my ideas and putting them into work in practice. And I feel that that's interesting as much as the academic work, because some of it turns out to be nonsense when you try to apply it. And then you should follow that. So for me, that iterative process is very important. And the second aspect of my work is hiding back. And in some sense, the Lancet Citizens Commission. It says Lancet Citizens Commission there. So this is shared with 3 other people. And I'm going to describe the composition of the commission intentionally, because the composition is very different. I'm one of the 4 co-chairs. The other one is a professional doctor, psychiatrist, Dr. who's also a professor at medical school, and probably one of the leading psychiatrists in the world, and runs India's biggest NGO, Sunlight, which is educating massively about mental health issues. As you know, mental health is stigmatized in India forever, continues to be so. There are people in my family who should have counseling and absolutely refuse it, even though they're very educated. So it's a problem. And Vikram is doing amazing work in educating people. So he's which he did at COVID as on values supposed to be people at level, which he deserves. With the third co-chair is my very close friend, who's years I like entrepreneur. And she represents sort of industries on the commission. And the fourth is probably a biologist, Lemann, who is now a university Gates Foundation also. So we have 4 people who are representative of their fields in some ways, and represent very different views on what the healthcare system should look like. And the whole idea was that India has made commitments to this notion of universal. Since 1946, the year before independence, there was a commission called the Board Commission, which very famously set out that India should provide universal and free healthcare to all the citizens. And very famously has failed to do that comprehensively 70 years later. But what we have not failed to do is continue to recommit ourselves to the idea of universal healthcare and continue not to deliver. So that's not to say that there hasn't been a lot of improvement. Life expectancy has improved from 45 years. Most people are 45 in the 1940s to the 70s today. So there has been improvement. Maternal mortality is down, infant mortality is down. Infectious diseases are generally controlled, vaccination rates are very high. There's a lot that has gone there. But in the interest of, but we have underperformed even other poor countries. Okay? So if you have a GDP control assessment of what our education should look like, we are very bad. This is what happened. So in other words, a lot of the improvement has happened in secular fashion across the world. And for some reason, we just are not meaning us, the collective Indian us, have not been able to practice. So why should there be one more commission? In the end, this would be the nth commission for in-person healthcare. So the starting observation was made by Vikram and me, saying that if you look back at the composition of all these commissions, who do you think is on the commission? Okay. What kind of person would have been on the commission? Bureaucrats. Bureaucrats, absolutely. Our bureaucrats on best commissions. Not so many. Couple of them, yeah. Who else?
And the department is also those who are in administration.
That's not the bureaucrats.
Because some of the doctors become.
Oh, I see. So definitely there were doctors, which is good. We want to make doctors. clear, and a lot of bureaucrats and some political appointees. Eminent people, all nobody's questioning the competence of anyone. That was a typical commission, right? Very well meaning. So, whose voice is missing? Whose voice is missing? That is a good description. Who else is there? Whose voice is missing? Public. How will you represent public on the commission? Can you say public? Who said public? How will you represent public?
Public representatives.
Okay, some selection process for member at large. Okay. Anybody else?
Civil society.
Advocacy body, civil society, or who else? IIMA, right? Private sector is always missing. What percentage of employment is delivered by private sector today? I think it's like 80%, maybe higher. Aspirations of the public sector, but actual healthcare delivery is largely private sector. So now imagine you're setting up a commission where the real facts on the ground are that the private sector is delivering. And those economists are here who say really preference, that they know what's best for them, that's what they do. But their voice is excluded from the commission. Society, which is super important in our country, all walks of life, including healthcare. Community organizers, community health workers. These days we call them ASHA workers, for instance, who are one of the best people of our health, sorry, ASHA workers. In the end, that's what really makes the difference. Not the fancy doctors, games, and so on. All excluded. So basically, you have a bunch of babus. I can't use the babus. It's a babu. Well-meaning, honest, competent people, and members of the elite institutions setting policy in ways that are, may I say, dismissive of protesters and concerns. And as a result, the report never had a snowball's chance in hell of anything ever happening. So these reports all stand on the. So when we set up this commission, we said, first of all, it's going to be a citizens commission. That's the first intention of choice. And we want to make sure that the voice of the citizen, both as a patient and a doctor, is represented. By the way, even though the doctors are on the commission, nobody ever asked the doctors for any input on any of the things. Nobody asks the public at large, what do you want for your health? So we set up a commission where everybody would be represented. So our commission has about 25 wards commissioners, so to speak, in addition to the 4 chairs. They represent, of course, the doctors and surgeons and so on. They represent the nurses. They represent the community health workers, the ASHA workers. Every people in the commission, everybody has the same voice. They represent the private sector. They represent the AYUSH. What is it? Unani or something. All the traditional forms of healing. Think about it in your own homes. How much of the treatment that you get, that your mom and dad, your nani or nana gave you, is AYUSH. In my house, we are the most over-educated family in the world. My house. Most of our treatment is associated with this. So de facto, that is the healthcare system. So why should they not be represented? So we made sure that the AYUSH team is fully there. Everybody is there. Health insurers are there. Pharma companies. Now, what would be the problem with this composition? What do you think? What are the problems?
Different stakeholders will have a different perspective and different demands. So to cater everyone's demands will not be something which is actually balancing things is difficult task.
100%. Widely different preferences, widely different prioritizations of what needs to be done. widely different. People with moral objective functions, who is the right thing or wrong. Widely different views on what is morally repugnant and therefore inadmissible. Right? So we set the ground rules in day one is that the chair set the commissioners. You're free to accept, or this is all unpaid. It's just pro bono research. So you're free to accept or not. If you accept, you commit to be respectful of other views. You can disagree vehemently. You cannot be uncivil and say that I cannot work with so and so because he or she is not a good person because he views it. So we actually had 2 or 3 eminent people who started the commission after one of the meetings said, we can't do this. That person is actually evil. Think about that. Think about that for a second. If I name the people that you'll be shocked. Because they are so eminent. They are people who everybody in this room would know once I said it. But they did not want to work with somebody else. So we stuck to our guns and said, luckily, they are. So why am I believing this? I think that when you do work that results in good change, in the end, it's a negotiation. Just like politics is a negotiation. If you see my colleague Shankar, who's Arizona business, and if you were here, he would say, it doesn't matter what I think about Trump or the other guy. Point is, he's there. Right? It's a fact of life. So I have to live with it and find the best. That's how we approach the mission. Is that we have disparate views, disparate preferences, disparate competencies. We all bring something in favor. I have different views on who is evil and not evil, whether beneficial or not beneficial. It's not relevant. We're not here to ask for a judgment. We're here to see how we can work together to deliver universal benefit. So this literally ate up the first 6 months of just agreeing on the ground. Right? So that's what's different about this. Okay. So I haven't even started to do half my time. I think it's a valuable thing to say because I think if this commission works, I would then my hypothesis would be somebody else can test. If they're smart enough to test that this is the reason it worked. And this is the reason that the other ones didn't work because they were there on a line. So somebody would be for that. That's not having a seat at the table. Get it done. Our plans may also not work because it is APM so complex. Usually they have cases to for 1.5 million, 1.5 million people. So the slides that I have are to say a little bit about the commission. I already did that. We did a bunch of original research. So in the end, this was 4 co-chairs, 20 to 25 commissioners. I'm forgetting the exact number, very diverse backgrounds. Each of them represented a large institution here. Right? So think of it as 20 institutions coming together. Another 25 PhD, postdoc, even faculty at other places as commission affiliates working with us. There are dozens and dozens of students. So, mota 200 people working on this for 5 years. Meeting once a month regularly, including through COVID, started with COVID, and then we more with the trash. We did a bunch of original stuff. We defined what we call it universal benefit index by district. The work was going on. People were free to publish research as they went on. So parents, triplets, groups of people came together to publish. The co-chairs all publish things in the Lancet. Lancet is the world's leading health journal. No reason why you know that. But we pay. And so things that they publish there, it's a peer review journal. So I don't even know whether a report will be published in the end. It's likely to be because it's already been through drafts of review, but that's not done yet. We did a citizen survey, which is your standard statistically representative sample, stratified sample. I think it's 50,000 individuals across the net in different ways. Calibrated to have less power to say things. And amazingly, it is the first time in the history of India that somebody has asked people what constitutes good healthcare before some grand pundit has decided that I'm going to decide what is good healthcare and write down the report. And then crash it immediately after. So we did that. And then a couple of our colleagues, Nachiket Moore, who's one of our commissioners, is a financial economist from the University of Pennsylvania. Interesting background because he was almost the CEO of ICICI Bank at one point, then deputy governor of RBI, now health economist. So Nachiket did a wonderful exercise with a bunch of us, just estimating if you, as a hypothetical exercise, if you wanted to deliver universal healthcare to all of India's citizens, what would be the per capita cost of delivery and on the adequate return on all factors, on human capital and financial capital, we put it. Any ideas what that number would be? If I asked you, on average, how much money would we have to spend, right, per person, so that on average each of us had universal access to universal healthcare? How would you answer that? This is a good question, by the way, in PhD interviews. How would you answer that? What? Maybe
1,000 rupees per person. Considering 1,50,000 crores per 150 crores of population. Because the budget for this health issues at national level is around 1,50,000 crores, including states.
But right now we're not delivering first level.
Yeah, we are not delivering right now. With the current scenario, it's around per person.
Okay, so that means that if we actually want to deliver, then we should spend more. Okay, so that's one way to estimate is to take what's currently happening. We know that that's not remotely delivering. And so then we figure out that's a lower number. It has to be much lower than 1,000.
And that is also not spent.
That
is the money. So that's the key.
You're absolutely right. Yeah, we have this beautiful system in India where there are pools of money that just sit around, they're gathering to simply part of money, but we bread. It's a brilliant system. What do you use? Oh, what do you use? What else? I still need methods to estimate or something like that, or guesses as to what would be the amounts. So far, nobody has asked me what defines universal healthcare. So the first thing we need is a basket of services, right? That at a minimum should include preventive, should include routine, general, non-preventive care. I got sick, something happened, I went to the doctor, and should include, tertiary and catastrophic care, right? So some agreed upon basket, which statistically is the vast majority of illness experience or pre-illness experience. So, and there are existing definitions in different countries that have algorithms and so on, so we can knocks them. So it turns out that one of the nice things about Nachiget's team analysis is that no matter how you do this, you roughly come out to 2,000 rupees per person is enough. You provide universal health. We've seen a really low carbon rate, but it turns out it's enough. When you try and do it in 16 different ways and different approaches. So that is actually published work. So you can go and look at it. It's really incredibly thoughtful, but also simple exercise. You do it in 16 ways and come up with ranges. And the ranges are all centered around 2,000 rupees, give or take. And it turns out that there are at least 10 states in India that are spending way more than that and are not remotely delivering this. That just means that there is a lot of allocated efficiency of these. So when the health community says, government is not spending enough, my first answer is, that is not the first vote of call. First vote of call is, as you were also saying, there's piles of money that are either not being allocated or are being completely misallocated and are not being. So there's plenty of room for reoptimization. It's easy to say, it's very hard to do. Why is it hard to do? Because it's all about relative power in politics and so on. And who controls the purse strings, who's getting sideways, and those words.
I just wanted to with the intent of spending, the government is not actually, because the doctors and the medical staff is not available to go to the parchment areas, remote areas. So the intent is also one thing which has actually important.
That's absolutely fair. That access has become less and less an issue, even in the most remote areas. And I think one of the positive things now is that because of the India Stack type digital backbone that exists, there is room to do something quite dramatic in the remote areas. Again, easier said than done because it's going to be a personnel to be at the last mile or the last 100 meters to facilitate that and people to interpret it. Yeah.
So this is about consists of the capital infrastructure also.
Yes, it consists of cost. So it's the unit cost of financing of the requisite capital infrastructure, then running it into the capacity utilization driven by actual consumption. So the analysis is explained, it's fantastic. So as an exercise, yeah.
So you have mentioned that like accessible like not a big problem in India.
No, it's not a big problem. It's getting because
Yeah, because when we look at Indian geography, the Indian geography is a lot of the tribes, a lot of the like remote areas, private areas. So for example, that when we look at that specifically the Gujarat district, so more than 100 kilometers they go and after then they are able to access the healthcare facility and that road services are also very
so completely accept that. I'm just saying that there is a lot of data, including in our report, that shows that access has become a lot better over the last few decades. But there are plenty of places where it's still extremely good.
India is facing due to the like political issues that were there and some politicians are saying you can stay with the healthcare facility on that location because of near to me and my like personal benefits.
I agree.
More spatial economy and service economy.
So both. I'm talking about a spatial unity getting into places. No. So universe that means universal. That everybody, regardless of whether you're remote or urban. And universal also means the package of services and medicine that you should be getting are all included in that. So both, in both senses. Then, because some of my training is in economics, I decided this production function based aspiration for what universal healthcare would need to do. So I think about universal healthcare as the output. I think about the financial capital that's needed to do it. I think about the talent that's needed. So the talent includes medical professionals and so on and so forth. I think about the technology as another factor, but that's sort of the supply side, if you will. Then there's the demand side. Do people know what to demand for healthcare? And the answer often is they don't. They're not been educated to do that. But using that production function framework, can I organize my thoughts? Yes.
Also, the benchmarking of the features in terms of from different states have been completely, which is
What do you mean benchmarking?
benchmarking things like CSC and a CSC and district hospital should have minimum of this. How district healthcare analysis reports of there is a huge difference in terms of states, in terms of districts also, which are very important. And also the difference between the private sector and the public sector healthcare facility is immense, due to which the manpower doesn't want to come to the public healthcare system.
All of this is correct. Now, one of the ways that the report tries to, the research that led to the report, tries to deal with the heterogeneous reality of India, right? Whether it's due to urban rural, it's due to remote access to topography, or it's due to social barriers, religious caste barriers, is often inherent to this. Barriers to lack of education. So in the end, the way the report is written is it puts out some principles and guidelines, and then it recognizes that the implementation of those principles and guidelines is going to be very context dependent. So in the end, it will have to be a process of give and take and bargaining in the local geographies to implement it. Maybe it's with the state government, maybe it's with the Model Clinic, maybe it's with the board, maybe it's with the IS officer in a particular place to say, how can we make this work as long as these principles are included. So all that is stuff that has to happen. But the purpose of the report is to put some broad guidelines that are research-based, evidence-based, and to suggest why we think that this is the viable path forward. Not an easy path, I think it's easy about changing that we have put it this is just a history of the mission. So back to 1946, I'm just going to get through this. So our commission is divided into work streams, each led by, say, 10 commissioners with diverse backgrounds, citizen engagement, governance, human resources, financing, and technology. Why these is seen by sensible aggregation of sets of issues that it was necessary to address. Probably collectively sufficient, but at least necessary to address. What are some of the things we did? I think this is what I wanted to highlight too. So some of our colleagues, led by a colleague at IIMA Bangalore, so it's going to what's the last name? Yeah, Mukherjee. I always talk about his last name. But under Mukherjee, led a group of people to come up with this universal healthcare index, ranking of districts. So here red is low level. This other bluish color is high in this healthcare, and the yellow is medium. So you can just see by district. And this UHC index is like, how would I say, it's a geometric mean of geometric means. The geometric means of geometric means. And each geometric mean is a bunch of things. So it's derived in a very simple but importantly reproducible and verifiable way so that somebody else will issue it and go back and say, I don't do that correctly, and leave that piece of it. But what it does is it gives us a language system to say, so we don't end up in this argument that this is a better district or that's a better district. You can actually quantify it in different ways. And the quantification is on pre-existing data that exist within India or outside India at the district level. And then where it doesn't exist, we have either gone and corrected the data of each district, or we are trying to extrapolate and make some assumptions about it. And also it's published work. So I'll give you examples of ways that happened in 5 years that we would identify an issue, group of people would come together and say, let's work on that issue. So at some point someone said, it would be really nice to have an index so that we know how far we are from this healthcare once we have the definition. Turns out that it doesn't exist, then it's a group that created, took 2 or 3 years to do, and got it published, and now it's an accepted piece of data infrastructure that we can use. And so on and so forth. There are about 30 or 40 different things that got published along the way as people work on this piece of this, and they come back and aggregate this quantity reporting call to the overall commission. So in a way, it's also an example of how cooperative work can be done, social science research work. Okay, what else could I decide here? Broader deep dives into discrete case studies. On the top it says, sorry, this is so small, citizen survey, a population-based survey. This was done by a professional surveying agency, but the design of what should know and how it is done is around the country. Actually administering the survey in a way that is representative. So it says, over 6 months, 50,000 households, from 121 districts across 29 states, blah, blah, blah. So this survey protocol, again, the questions are public, so they are available on the website. That would be remember, it's the first time anybody has asked anybody, what is it that you would like as a doctor, as an AYUSH practitioner, as an ASHA worker, as a patient, as a surgeon, as a pharmaceutical company. We're out there serving everybody. It's actually listed people's preferences. And there are other research that we do on that other people have done that seem relevant to this not free right now. This is a graphical representation of a very complicated health system that exists in India right now. Basically, the right side is a private sector representation of public sector. On the bottom here are the ASHA workers, the public sector. Going down to PHC, CHC, hospital, subdivision hospital, and this side of the corporate hospital, so to speak, whatever the big ones, Paulo and Reimagining, this and that, those kinds of things. So this is the complication of the index. I already spoke about this. Time. This is the geometric mean of these 5 categories. The 5 categories that were are the protocols in place to deliver productive and child benefits. There's something to do with infectious disease, something to do with NCDs, one of the big changes in healthcare in India in the last 30 years is when you look at the history of how these rules were set and institutions were created, and rules and protocols, they're largely geared towards infectious disease management. They're geared to the time that we didn't have the vaccines or vaccine capability, and tuberculosis, things that spread by infection. So the dominant health problem. It's still a problem in India, but given that our vaccination system actually is extremely good, that stopped being the main problem. The main problem is rising rates of NCDs, non-communicable diseases. Examples, cancer, heart disease, cardiovascular, diabetes, all metabolic disorders. Is this? I think India is the metabolic disease capital of the world, unfortunately. Particularly Indian men have lost the genetic lottery. They're one of the most prone subgroups to metabolic disease, unfortunately, in the world. But what that says is that we've got a health system that is completely anachronistic, is out of sync with the needs of the population in a way that is dramatically different. And dramatic is the right word. So my good friend Lee Shetty, who's a surgeon in Bangalore and part of our mission, he says, this is the only country in the world where the median patient for me is a young 35-year-old man coming in late-stage heart disease. You won't see that in any other place. Not women, it's a man. And the woman is that is supporting the man, the whole cascade of problems. So, NCDs give a separate category for it. Service capacity and access issues. You were talking about the growth and access. And then this one's important, financial risk protection. An aspect of universal healthcare is that you should be able to get the care but go bankrupt again. And that is one of the most common causes of bankruptcy in India, is a catastrophic illness. That if you're not able to get free treatment in a public hospital, which legally you're entitled to, you often can't get. When you go to the private hospital, the rates they charge 5, 10, 15 times greater than the public hospital. You take a loan at a high interest rate, and you rapidly get into a cycle of debt you can't get out. So those are the components of UHC that are fairly well thought out and measured and so on. So but you could do a USC index that is only based on finance, and then you would see whether it has stocks. And it becomes a tool for which you can manage. Yeah, all kinds of insurances are included. I don't remember the actual composition of the index. It's on our website.
I just want to know how it is incorporating medical insurance, medical inflation. Insurance premiums are closely linked to
Yes. Yes. I don't remember the details to be answered, but access to insurance is either the public or the private line. But the numbers say, as you know, all the insurance is available in India for the most part doesn't cover outpatient services. It's all inpatient. But even the inpatient part is almost hopelessly ineffective. Only 2% of inpatient treatments in under 2% of inpatient treatments in private hospitals and 7% of inpatient treatments in public hospitals is actually covered partly by insurance. In other words, it's almost a bust. We've not solved the moral hazard and discussion problems with insurance remotely. But then we had a conversation about there's so much mistrust between the insurance companies and between the patients and the doctors, between the patients and the insurers, that it's a complete breakdown. So the insurance regulator, I know, has IRTA, some of our commission members are members of the insurance commission also. So they were just saying that, so here's an example of how the mistrust works against us. The insurance regulator historically has said, in order to open a new insurance company, you need to have a paid-up capital of 1 billion rupees or something like that. Okay? I think that is something like 8 times more than you need in Europe. Why are they doing that? Because they are so distrustful of the hospital that they're saying they allow for a lower barrier to entry. Small people will start insurance companies. They will not be able to deal with the hospital. Companies will go bankrupt, patients will be left alone. But the unfortunate cost of doing this huge thing is that you're left with very few insurance companies that have a lot of market power. And that cycle perpetuates itself. So how to break out this is an exercise in institutional experimentation. It isn't clear. But that's one kind of chagra that's going on in the background right now, in the financial markets and the hospital. And there's a lot of what you would expect, which is mutual relations. The index is very correlated with poverty. These are the indicators in the index. I'm not saying more about that. So another piece of this was to do, we sampled high-performing health districts, some mid-range health districts, and some low-performing health districts. And then just did very deep dive in the issues. There's some quantitative stuff, there's some measurements, there's some deep dives. We were trying to put together, trying to triangulate an overall picture of how this could be made. This is something I'm very pleased about. I've already said very clearly about this. But we find that for a lot of things, questions that come up in doing the work of the commission for 4 years, we immediately find that we end up going back to our own citizen survey. Because it is the only source of data for science commission. These data have never been collected before. This is all going to be in the public record. So these data will be released to the public before use, replication, augmentation, critique, which is the way that the research should be done. One of the things that really surprised me is that regardless of whether you look at outpatient currently or for the future, inpatient currently or for the future, and you ask people, where would you like to be treated? The vast majority of people say we would like to be treated in the public sector. Of course, the assumption is the public sector will be reformed. A lot of it is affordability because they know that the private sector, you have the wins of somebody who is in a position to overcharge you and probably does overcharge you. So, and also, I think the level of mistrust with the public sector has been reduced after COVID. Because during COVID, people saw that a functioning public sector was absolutely essential for survival. And the COVID-type situation, sadly, was recovered. Right? And a lot of good things came out of that, the vaccination system, the COVID platforms, and so on. that will be very helpful in the future. But I think that the trust levels for public sector went up. And my view is that that's a really hopeful thing, because in the end, university healthcare, the advocacy they were going to do this report, even though I am generally a very capacity of the private sector, doing great things. In the end, our main advocacy is that we have to strengthen the public sector as the key adjudicator and deliverer of universal healthcare, with the private sector playing a supporting role. Regulated, managed competition to be used to both discipline the public sector and to do the things the public sector can't do. That in the end is one of our big central architectural recommendations.
So, what percentage of people are from people who are from upper middle class and upper class?
So this is
that will be actually that will depend on this.
Actually, that's not wrong. First of all, this 50,000 people is what's referred to as sophisticated stratified random sample. It just means that all these groups are represented in the right proportions of the existing population. So, rich people are represented, very poor people are represented, people in the lower are represented, people in the south are represented. And 50,000 turns out to be about the right number to capture enough variation to get statistically defensible correlation. And it turns out that this preference for the public sector seems to be pretty robust.
Also, the academic practice sampling strata, different strata sampling, different rural area, urban area, remote and
anything that is on our website. The website is citizenshealth.in. Citizenshealth.in. Everything's on it. And if there's something not on it, you can just write it's not on it, it's something to work on. So what did I mean by this? Let me just say a couple words about this because then maybe highlight. So this is the current status quo, the way my mind internalizes. Okay? I just said, let's think of people said the patients that why don't we have what the doctor's doing? Right? What is the patient experiencing? The patient is experiencing extremely fragmented care. Right? You get sick, if you happen to have a good primary care doctor, you go to the primary care doctor. Primary care doctor isn't really connected in a systematic way to secondary care or tertiary care. He or she will send you to wherever he has a relationship with. Right? That person will do whatever he's told to do, but has no access to the continuity of your health experience. Right? So is reimagining anew your entire body function in a 10-minute conversation. So you're almost doomed from the get-go to get suboptimal care. And then if something goes wrong, you go back to whoever is available, wherever is available, and restart the process. So the patient is frustrated, and those who are well off find their own guards around this, right? As we did when people growing up. But for most people, it's not possible. You take what's around you, and it turns out to be something. Insurance is underpenetrated and may be used. We just had that, conversation with this. And the patient is increasingly interacting with the pharmacist is functioning as the PCP, the primary care place. So often, the citizens are very clear. Who does your medicine? Pharmacist. Is the pharmacist trained? No. But he knows. He said, we give you something. And we have done now statistically, not me, one of my colleagues, I digital labs, done these brilliant analyses where he takes fictitious patients with stylized, simple diagnostic criteria, the kinds of things that you would do in first year medical school. My daughter's in first year medical school in the US, so I see what she is doing. And you send them, and then you see what the person prescribed. 80% of the time it's utter rubbish. 80% is not exaggeration, it's actually 80%. It's published. 80% of the time, what the person is saying is completely off base. So this is the state of care. The quality. So on the one hand, you can say access is improved, but the quality has really not improved. And that, I think, applies equally to rich people and poor people, as it turns out. On the provider side, it's equally frustrating. The physician is frustrated that he or she has no access to really the history of the patient or what happens to the patient after that. There's neither forward nor backward linkage in care. Therefore, the physician is unmotivated. Because people become doctors because they want to be caregivers. Of course, money matters, but beyond that is the professional satisfaction that I deliver care and I saw to do with something like it's missing in some way. So they are frustrated. They have an incentive to the way the economics work. Any human being would, to some extent, later or lesser, end up overpaying. All fee for service. The more I give you, the more it's the older you say, the compounder will be sent you something. It is back here some hours and charge for it. So this is an important one. Line item budget creates inflexibility. What do I mean by that? In the public sector, the way the state, because of mistrust, tries to control fraud and malfeasance is to say, okay, each line item we are going to measure you on. How many needles you use, how many napkins you use, how many patients walked in, what happened here, and any deviation we will pay us. So imagine what that creates. It creates stress, it creates utter inflexibility. Better to say, in a model of integrated care, that we will give you X rupees per person per month or per person per year in your area. You decide how to use it. If you save money, you keep the rest of the money, so you can send it. Do it right. But we will hold you accountable for results. And those who do better will get better terms over time. Something like that. We have the opposite of that, right? Because it's governed by mistrust throughout the entire system. This is a good indicator. This is a representation of total health expenditures from over the last 10 years. And the only thing I want you to see is this balloon line, balloon gauge, is out of pocket expenditure. How much is the patient paying out of pocket for treatment? As opposed to relying upon government handouts, private insurance, donations, etc. And you see that this number, 65% going down to 48%, is still among the highest in the world. This to me is an amazing indicator of a poorly functioning health system. When everything is, because think you have to shell out most of the money in your pocket. You're going to ration care for yourself. You're going to think twice before you do it. And if you do that, you will catch your medical problems later. When the evidence is that it becomes 8, 10, 15 times more expensive. Rather than going to GP, because it's all covered, getting preventive care ahead of time and saving society. So we have designed a beautiful system that has it all exactly backwards. Exactly backwards. So we're getting results that are basically nonsense. When we have enough money, the money is sloshing around the wrong thing, the wrong time, the wrong place. And people who are benefiting from the current misallocation obviously don't want to see change. So it's like a game of chess. We are the policy makers, and we want to rearrange the chessboard so that you get a better outcome. How do you go about doing that? Chess players have this because they are more of a right now. That's the creative game that has to be played. And it's a lot of fun. So I don't have time to talk to this, but I just use this schematic. This is what I meant by production function approach. That look, in the end, to deliver universal healthcare is the output. We also need informed customers, informed patients. So we need a degree of healthcare literacy in a country that is currently still missing. It's provided with this system. And we need efficient factor input markets. We need efficient capital markets, we need efficient markets, we need talent, and we need efficient use of technology. So the rest of the slides are all elaborations of these things. And we also need one thing that I found intensely puzzling about this entire process was in the country where I live, the US, healthcare is almost an issue these days after immigration. But other than that, healthcare is an issue on which government is surprising for. In India, healthcare has recently not even been on the manifesto of the election parties. You read the manifesto of the BJP, the National Congress, Ahmedabad. Until the last election, none of them mentioned healthcare once. Why are they not mentioned healthcare? because they know no citizen is holding their feet to the fire. Why are they not holding their feet to the fire? This I don't know. To me, it's a huge political party cost. Thankfully, the last election, finally, I think the Congress put out a manifesto that came for, and then immediately copied it. So at least that has entered the system for people to start asking how come healthcare is not good. And now, today, like in the citizen survey up, if you ask people what are the top issues, healthcare at least shows up in the middle now. I intend to hold my elected representative accountable for when I next go to court, which is ultimately the driver of change. Because the politician feels like, I never got there, I don't have care. Then you will start seeing political change. And it will happen. So, we're sort of over and out, so I'm going to stop talking. There's a lot of interesting stuff quickly on technology that's happening, which is super interesting. A lot of it is coming out of, not just on drug discovery side, but also on the digital backbone, on remote access, on telemedicine, on using genome sequencing and AI techniques to do sort of instant, real-time surveillance, building the infrastructure. I'm involved in those projects with the digital science. We're rolling out these centers all over, so that in the future, academics that come will be able to save days and weeks before it shows up in mass images. Then you have a much greater chance of arresting. So those are some of the positive things that are coming out of the technology side. On the finance side, I would say the massiveness. That there is enough money in the system already to do much, much better. We actually need more money on top of that to get to global standard to universal healthcare. But as a start, we don't need to ask the government for better money. We just need to have the political will and the political smarts to be able to manage the existing economy. Simple thing is something called the ESIS fund, which is a way of forced contribution from, I think it's public sector enterprises. What is it called? ESIC. We are going to ask you, this is a fantastic thing, where the state has been collecting this money from public sector enterprises, private also, and then goes into a pool, the way of activator. It goes into a pool, and that pool has become as big as $10-15 billion, which is not being. The payout ratios from that are legislatively supposed to be in the 90%. It's hovering around 50%. Nobody is saying anything. The pool keeps expanding each year. People take that. It is an amazing system, and nobody is accountable for it. And the bureaucrats sitting there saying, better not to do anything than to do something. Because planning so something will happen. Those are not going to do it. This is what I mean by there's no regulation of the system and holding people accountable for it. So my summary view is that I think there are plenty of places where there's lots of low-hanging fruit. So I think, if the median universal healthcare index are from 0 to 100, today, according to our team's analysis, is about 44. Big picture, I would say you can go from 44 to 55, 60 without any more. You just need to, there's 6 or 7 things that are politically contentious. We need to take them on and fix them, and they are fixing them. The answer is clear. It's just few people are holding it up. That's one thing. Second thing is the trust in the public sector has gone up, which is fantastic. Because I think it's important. So that's an opportunity to capitalize. The third thing is the tech stack. The tech stack is dramatically improved. Sequencing and surveillance technologies will be dramatically improved. So on that front, we have the big problem that is not easily fixable is this fragmented delivery, where there isn't a single person who has visibility into a person's care for long haul. And that is a killer for NCDs. Because if you're a cardiac patient or a diabetic patient, you need continuous care every single day for the rest of your life by someone who knows what's going on. And you can't do it by saying, okay, I'm going to say that with doctor right now. Doesn't work. Especially when you have no aggregate representation of life history, medical life history. So those are some of the headwinds and tailwinds, right? Anyway, so I thought what I'd do with the 1 hour that I had was to give you a sense of how we went about this very large problem. Got a lot of conventional publications because academics need to be publishing in ways. But in the end, I think we're going to produce, I hope, to be a very influential report. And more importantly, I hope it will keep some change. So thank you very much for your attention. And, we'll go to the next slide.
Tarun, we have MBA students and some researchers who are here. So if you talk a little bit about who are aspiring to concept, someone like Jorge, right? It's navigated through corporate and philanthropy. It's also with Gates Foundation for some time.
So yeah, so what's the pathways foundation? Yes.
What's the pathways you see?
So, I mean, I think, so I think Lakshmi is an excellent example of someone who, starts out as an anchor, only one anchor. It was really big. And is good at it and goes up the corporate ladder, at least that's it. And then decides at some point that he's going to shift to sort of more of a research orientation. And ends up really sort of immersing himself in the type of work. So we are good friends. I sometimes write there's a recommendation for institution to be applying something, and understand this respect for it. But when he wanted to understand the phenomena, he didn't. I don't need to be pejorative, but he didn't sign up for, I think, what you call here MVP. Automatically said, I'm going to go to the consulting. He said, let me go understand the phenomena. And so I remember he went to set up his own civil society organization outside of Chennai, which is where I think he was originating from, basis, and began to actually understand the health phenomena which he had become interested in as an actor. Right? And so his expertise is on the intersection of health and finance. And you're actually just building on that expertise. Once you have that unique expertise, I can't think of any, thing, the intersection of finance and tech in this country that would not be mentioned. I think it's a nice example of someone who has a domain competence, in this case, health, and finance, the intersection of it, which is a big space. And so anything that happens, whether it's on the corporate side, consulting side, policy side, civil society side, even a voice. The name of the game for me in career life is that you want to be a voice of the most interesting people. That's the way I visualize it. Say, okay, if I'm interested in X, and the most interesting people in the world who know something about X are getting together, how do I set myself up so I'm invited to be one of those? Whatever the issue, it might be something conventional, like being a CFO or a listed firm. It might be being an academic on some particular topic. It might be a director of butterflies, more like you. But whoever the best people are on that, how am I given a seat at that table? That to me is the North Star. Life doesn't go in a straight line, it's zigzag. But as long as that zigzag is going towards something that we find appreciated and motivating, I don't think it matters how good that is. So that's a bit of a philosophical, but also a practical stuff.
Maybe what you're saying is pursuing domain expertise, opportunity that how we build that.
I think that's a good thing. Yeah.
That's okay.
So my own, not that I just I'm certainly happy with it. So maybe that's a good thing. That's a good thing. You do something that you get up in the morning, you're excited to do it, and you're professionally satisfied, and you're respected people around. So I certainly have that, which I do But our path is very crazy. So my family owned a lot of engineering businesses in Bangalore, and I thought that's what I would do. So I would run the engineering business. So I became an engineer. I wasn't really passionate about it. I said, oh, that's what I do. At the end of that, there was a Wall Street trade going on, so I went to Wall Street. And I realized that's not really, that is not interesting to me, not really fun for me. Great fun. So I went back to school at the business school, became an academic. Not really thinking like actually. But after that, then I decided that was the first time, at the beginning of my academic career, that I asked myself, what would really make me happy? Honestly, I was really happy to ask that question then. And I decided that I would like to work on development, India's development. Out of whatever interest, intellectual interest, idealism, whatever you want to call it. And so then I just started working on this with whatever tools I had in my school, which is basic knowledge in economics, much higher knowledge in mathematics, which I enjoy, so that, and try to find a path in that big tapestry which started to and go through effort and up to be relevant. Found that a lot of pathways open up. Offers to your boards, go to the Lakshmi practice, go to the Davos meetings, work on this, work on that. And that's when I had the light, my mentors were able to tell me exactly the way you just said it, which is think about the thing that teaches you the most. About whatever it is. So you're saying, to this day I say, I only speak about development. Everything else is in detail. That was very good advice. So then I began to make things that I would do that. I would do that only as long as they were adding to the and I was contributing to that. Then I would move on to something. That's very straightforward. Then at some point I decided that actually starting my own companies would be a very good experience. Because in the end, in the heart. So, why don't I try to create something in the heart? Which is unusual for me. So I did it. I built 10 companies now. Really successful. Not a million. But more importantly, really taught me about research. And I'm still doing that. So, whatever that's going, I think the way this is a good starting. Something that's contributing to expertise on an issue you care about is the answer. You guys have to wrap up pretty fast. Any other critique? Any critique? Yes.
This is a bit different from the last session. Because you were here. This institutional voice that you talked about, and today also the whole, a lot of people cite and this building. But one question I keep on asking is, how long will we say that emerging economies have this institutional void? Is it posing other indicators of
This is a good question. So in our thinking, so that idea I developed with some colleagues but in our thinking, that in the end, a market is simply something that I cite and says that's all. It's a set of rules. We have to make them clear for people so that the lions says they can find each other, and when they find each other and they decide to do a deal, then that deal is then able to be consummated. And that if it's not completed satisfactorily, then whoever feels that they've achieved it has some recourse. That's all the market is. It could be a market for CEO services. For buying chocolate, it could be a market for modeling chemicals, it could be a market for intellectual property business. It's all the same. Right? And the taxonomy that we developed that has turned out to be very useful is just, frankly, a list of kinds of things that you need for markets to work. Not every market, not all the time, but generally, you need these things for it to make sure that information flows and contracts are closed. And that gives you a starting point to say, now, to answer your question, one of the things we realized after formulating that is that what you call the missing institutions at a point in time are very much a function of, for want of a better way to summarize, the technological and geopolitical state of the world. So as every new technology develops, I think new ones will create. Let me give you an example. In the early days of what we now think of as the World Wide Web, when first hit people's consciousness, it was like being in a developing country. There was no information about anything. You didn't know where to go. You didn't know which was the good browser. You didn't know what the browser was. You couldn't find it. You couldn't know. You couldn't tell whether what you found was right or wrong. Which is just like landing in the Congo and having to say, I can't find it. Very mathematically and abstractly, they were both unknown emerging markets. One was emerging technologically, one was emerging geographically. And the reason I'm saying that is technological change keeps on opening up the institutional world. Today, if you look at, I just referenced genome sequencing in the context of surveillance. If you look at genome sequencing, it is a widely understood new technology. And how it's going to be used, what is the fair use, what damages. Those rules are not emerged in society. In other words, those institutions are not. So my answer is there will always be institutions. What you decide to call an emerging market or not an emerging market is a question of that. But there will always be change. And every time there's change, there will be new opportunities in market transaction. So those new opportunities will have to be adjudicated by society. That adjudication process is a political contestation, like the one I just spoke about. That takes time. And during that time, use our words. And that opens up both opportunities and threats. And a void in mind, that something is a double-edged sword. It's something that makes it difficult, but it's also an entrepreneurial opportunity to do something about it. Quick answer. Actually, it's a very abstract answer. Think about risk. If you don't like it, then you try something else. Right? I think the last question. We are on the board. Nothing on the card.
So take off different public health policies which are different houses. And I think the goal of all these policies are very the same.
Yes, like what?
But they are not the needs of the people. So once you take on that, let's say AYUSH or different
Yes.
which has a bit of that. So what the hospitals they admit you and they
take the money. Treat you to 5
Yes. Without giving the proper care, they discharge you from their hospital. So what should take on such kind of policies?
So, AYUSH is relatively new. So the person who created AYUSH is one of our questions also. So we had access to all the dirty documents. It's a difficult project. Okay, and it's in early days and has bugs and bugs have to be worked out. But I will just say that this particular problem of indemnity insurance, like we're dealing with a certain amount of money, is a problem in my home in Cambridge, Massachusetts. You have, for instance, dental insurance given up to women. And the dentist doesn't have that. The dentist does, will look at how much insurance you have and will say, these are the treatments, this is going to be covered, this is not going to be covered. Or this will be your copay and this will be your excess balance living. So you decide. That is not responsible. Because you go out with your teeth, whatever is happening. It's not India's. It is an insurance policy. That said, lots of things that are still being done. Insurance markets in India are super, health insurance markets are super ridiculous. So it is not working yet. But I think the good news is that the initial experiments have started. So I'm hopeful. We have to do it because you can't not get it done. So guys, thank you so much. So nice to meet you.
Thank you for coming.